بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا محمد معلمنا وقدوتنا صلى الله عليه وسلم. اليوم سيتم الانتهاء من موضوع الهايبوناتريميا للتحدث في موضوع مهم أيضا بالحلقات القادمة. وإن شاء الله نحاول نكون غطينا أهم الأجزاء في الهايبوناتريميا وأهم الحالات اللي ممكن نشوفها في حالات الهايبوناتريميا. وبعد تحضيري لهذا الموضوع اكتشفت فعلا ان الهايبوناتريميا من الموضوعات ان انت صعب فعلا تحضرها او تنهيها في محاضره واحده، وصعب تغطيها في محاضره واحده. والله المستعان، ونسالكم الدعاء بالتوفيق ان شاء الله في المحاضرات القادمه، وان شاء الله تسمعوا محاضرات قيمه في الفتره القادمه باذن الله. بس نفكركم بالهايبوناتريميا. احنا بدانا ان الهايبوناتريميا الديفينيشن بتاعنا كان الصوديوم less than 135 whatever the number. After you see one patient or consultation with hyponatremia, you should check serum osmolarity to classify your patient or your hyponatremia patient, either isotonic, hypertonic, or hypotonic. Hypotonic already we discussed in the previous presentation. Just the remaining two parts for us should cover all these main topics: hypertonic hyponatremia or hyperosmolarity hyponatremia, and isosmolarity or isotonic hyponatremia. This is the pseudo hyponatremia, and the cause of this pseudo hyperlipidemia or hyperproteinemia. Hyperproteinemia like in multiple myeloma. And hypertonic hyponatremia, we saw the patient control the blood sugar. This patient has hyperglycemia and mannitol, glycerol, and glycine, maltose, and sucrose. This is the main diagram or main algorithm to classify your patient when you see. Hypotonic, as we said before, this hypotonic we already discussed in the last presentation. Just to remind you, you will check your osmolarity and urine lyse. If your osmolarity less than 100, you should take good history from your patient. Maybe your patient is psychiatric problem or psychogenic, lead to psychogenic polydipsia or recidivism or peer potomania, and we'll discuss this also. Just this patient need only just free water restriction. If your osmolarity more than 100, we'll go to second step as we discussed before: volume status assessment, blood pressure, pulse, and systemic examination for volume assessment. Either your patient hypovolemic or hypervolemic or eovolemic, and we discussed all this in the previous presentation already. With the remaining for us, we need to concentrate today on the remaining parts of hyponatremia. We'll discuss now the first part remaining: hypertonic hyponatremia. Hypertonic, this hyponatremia, the delusional hyponatremia, this as in the case of hyperglycemia, mannitol, glycerin, maltose, sucrose. We'll discuss this hypertonic delusional hyponatremia. We have intracellular fluid compartment and extracellular fluid compartment. This is our body box, or this is a closed box already divided into extracellular compartment and intracellular compartment. Just to remind you, intracellular fluid compartment is around 2/3 of, if you, for example, if you have patient 60 years old patient, his weight 70 kilograms, total blood water for this patient 42 liters. And you know, sodium mainly extracellular in the extracellular fluid compartment. And we divide this 42 liter, 2/3 intracellular fluid compartment and 1/3 present already in extracellular fluid compartment. Just to remind you by this and this, extracellular fluid compartment, this include intravascular and interstitial. Intravascular and interstitial. This covering around 3.5 liter from 14 and this 10.5 liter. And this intravascular 28 liter, 2/3 and 1/3 divided for the extravascular fluid compartment to intravascular and interstitial. Now, as we will return back this extravascular and intravascular fluid compartment. Okay, we have now hyperglycemia, glycerin, mannitol, whatever, and all this increased concentration of this whatever hyperglycemia, mannitol, glycerin, all this will be in extravascular fluid compartment, and this will increase the osmolarity here and the osmotic pressure, and this will draw water from intracellular fluid compartment to extracellular, and it lead to increase this size of this compartment. As we'll see here, water will draw directed from hypotonic to hypertonic, from low concentration gradient to high concentration gradient, from low osmolarity to high osmolarity. By diffusion already, special fluid will, water will draw from intracellular fluid compartment to extracellular fluid compartment, lead to decrease the size of intracellular fluid compartment and will increase extracellular fluid compartments. This includes intravascular and interstitial. And this is the main cause of hyponatremia. This is a dilutional hyponatremia. Just only the water amount increase in the extracellular fluid compartment by the same amount of total body sodium. Hypertonic dilutional hyponatremia, as in hyperglycemia, sodium will decrease by 1.6, some books write 2 for each 100 milligram glucose. If for each 100 more than our baseline 200. If your baseline 200, each 100 increase on this 200 milligram per deciliter, your sodium should be decreased 1.622 for each 100 above 200. Or if you measure by millimole, I think 1.6 to 2 millimole, above 5 millimole per deciliter glucose. Whatever, this hyperglycemia, just your baseline by milligram per deciliter, this is common in our country. If your baseline 200, any increase 100 above this 200, each 100 you should decrease your sodium by, will decrease your sodium by 1.622. Other example for hypertonic dilutional, we patient using mannitol after this patient, especially with neurosurgery patient or an ICU, and the osmolar gap. This osmolar gap, this is measured and calculated the difference between, we found this more than 15. And this, as an example for this hypertonic dilutional hyponatremia, we'll see in IV immunoglobulin and the glycerol, glycerin, maltose, sucrose, as we mentioned before. Okay, as regarding glycine and sorbitol induced hyponatremia, this glycine and sorbitol, no concentration gradient, just via expansion of extracellular fluid compartment, not water drawn. As we know, intracellular and extracellular compartment will give glycerin. We are using this especially post-surgery, inter or intrauterine surgery. This glycerin particles will stay in extracellular compartment. And they just do extension only, not drawing water, just extend it there and retain water by this isotonic gradient for this extracellular fluid. No drawing water, just expansion of extracellular fluid compartment, and this lead to dilutional hyponatremia. Glycine sorbitol induced hyponatremia. Glycine is isotonic solution used at irrigant intrauterine surgery. Large volume absorbed from abdominal cavity that expand the extracellular fluid volume and cause hyponatremia. This glycine at the end metabolized to urea. Treatment only if symptomatic. If the patient symptomatic, you can treat whatever hypertonic saline and other measure. And otherwise, if no symptoms, just wait until the patient will start to be diuresis and will start get rid of all this extra fluid retained in his body. And the sodium will correct by dramatic response in the next 2 days. Just treat only if symptomatic, otherwise just observe, okay? It's clear now? Second part, we need the pseudo hyponatremia, isotonic hyponatremia. What means by pseudo hyponatremia? We'll discuss now. This is the second part in our diagram here. Just to remind you, I'm covering all main topics. Hyperosmolarity we know now, hypertonic hyperosmolarity, as a hyperglycemia, mannitol, glycerin, other. And will talk now isotonic and isotonic hyponatremia. This is other name pseudo hyponatremia, either in hyperlipidemia or hyperproteinemia. Okay, we'll go now. Okay, as we know, component of all blood, our blood component, plasma and plasma water. This is all blood cells here in the red part is around 40%, white blood cell, red blood cells, and platelet. 4% only proteins and lipids. This yellow, like yellow part, and this like blue and with blue dots. This is the water. This part is and blue, dark blue dots. This electrolytes. And this is the sodium, what means sodium, and other electrolytes, but this our water, this water around 56%. And we'll just explain this for you. This is the normal ratio for each part, and we'll see here our normal this proteins and lipids and this water content with electrolytes, especially sodium. Patient with hyperlipidemia and hyperproteinemia, all this part named plasma volume, and this plasma water, and this part contain lipids and proteins. This plasma volume here include all this part by lipids and proteins and water content. In this hyperlipidemia and hyperproteinemia, we'll find this total is around double amount of water and electrolytes. This lipids and the protein here increase inside in pseudo hyponatremia. This give you pseudo hyponatremia reading low sodium. We'll clarify in this. We have normal lipid and protein volume here, and this is plasma water, and this cell volume or cell component. When we are measure, the lab will report only sodium here in the plasma water here. But actually lab actually measure this sodium in the plasma volume. But in normal person, this small amount will not affect your result. Will be appear normal. Okay, it's clear now. In patient with pseudo hyponatremia, and this lipid part and the protein part increase inside near double amount of plasma water, and the lab lab report this plasma water electrolytes or sodium. But actually, the patient lab measures this by according to the method of our technique using to measure sodium in our plasma. Already the patient taken the sodium here and reported for you this sodium, and by this amount, double amount of plasma water, when patient was hyperlipidemia and hyperproteinemia, and this will give you a wrong number or pseudo number of low sodium. Pseudo hyponatremia seen in cases of hyperlipidemia and hyperproteinemia, multiple myeloma, hypergamma globulinemia, and the plasma osmolarity is normal, low serum anion gap. The most common question will ask it for you, multiple myeloma. What is the characteristics of multiple myeloma? Don't forget this patient with low serum anion gap. And the treatment for this pseudo hyponatremia is none. Don't treat any pseudo hyponatremia. ABG with ion specific electrode will detect sodium. This ion is not flame photometry. Flame photometry will give you this wrong reading of hyponatremia. Ion specific electrode, ion specific electrode will detect the sodium in this amount of plasma water, not all the plasma volume. This ion specific electrode, you can do EBG to be clear what is the actual sodium in your body by ion specific electrode. If you measure this total plasma volume, this by flame photometry will give you wrong result of pseudo hyponatremia. I hope that's clear. بير بوتومانيا. بير بوتومانيا أنا بصراحة شفت الصورة دي، أنا ما أعرفش ده بيدعي ده ولا ده بيدعي عشان هيشرب، ولا بصراحة ما لقيتلاش تفسير. الله المستعان. البير بوتومانيا. There's different type of beer. This will classify out under term or big topic, poor solid intake. Beer potomania, this is our tea toast syndrome. This patient, we have group of patients with poor salt intake. Especially will classify under this group will classify two big subjects, beer, botomania, and the T-toast syndrome. We have urine volume. Our urine volume contains urine solid excretion per day and urine divided by urine osmolarity. We have normally urine solid excretion in normal person around 800, 700, 900, whatever. From 800 to 900. This normal urine solid excretion per day. Okay, from where? Just normal urinary electrolyte and normal urinary urea and electrolytes. This equal urine solid excretion. We have sodium and potassium. We excrete around 150 plus 50 around 200. With accompany anions around 200. I think the total here around 400. Normal urinary urea catabolism from our catabolism daily around 75 to 100, and diet around 50 millimole per 10 gram of dietary proteins, 50 per 10 grams, and the total will be 400 millimole per day, like 400 to 500. If you calculate around 800 to 900 per day normal urinary solid excretion. Don't forget that. And clinical setting of low solute intake, alcoholism, beer, botomania, anorexia, tea, and toast diet. This low salt intake with this diet. From diet, the patient not taken well, especially patient on alcoholism, on beer, botomania, and anorexia, tea and toast diet. Poor oral intake, no protein and salt intake over days. When this patient will see in geriatric patient, when you saw geriatric or rehabilitation, this patient, elderly patient and neglected already, patient not taking good care at home, the patient with no protein, no salt intake over days, long time, seen in elderly. Most elderly patients, you will see this syndrome with a slight decrease in GFR. The patient named tea and toast diet. Hyponatremia with high water intake. This patient just taking water and just tea and toast diet without any salt, without any protein. And this lead to hyponatremia, and especially if patient with low GFR. Hyponatremia from high water intake without salt, without protein. Urine osmolarity for most of this patient will found less than 100 millismol per kg water. What is the treatment of this elderly patient? High protein salt diet. Just dietitian review. Dietitian consultation to adjust this patient diet for high protein, high salt intake. Beer, botomania. We have one patient who came already, just for example, I have consulted last week for one patient around 71 years. He's drinking around 3 liters per beer per day, and he came by sodium around 118, from his baseline around 126, 127, and the patient was congestive heart failure, also on diuretic and others. Just I brought this patient in alcohol restriction, free water restriction, and just I added next day maybe sodium chloride. I didn't urea tab, not sodium chloride, because the patient already just heart failure. We put in urea, just 20 gram BID, and his sodium returned to normal within 4 days. We think just assume beer consumption of 5 liters. Just for just example, we assume beer consumption of 5 liters. Each liter contains 2 millimole per liter, 2 millimole per liter sodium, and the potassium 10 millimole per liter. Sodium intake for this 5 liter around 10 millimole, potassium around 50 millimole, 5 multiplied by 2, 10. 5 multiplied by 10, 50. Obligatory urea excretion in normal person around 90, urinary excretion. And the total solute, if you calculate this, around 150. Assume urine dilution of 50 milliosmol per kg in normal kidney function. Assume urine dilution of 50 millismol per kg with patient with normal GFR. Urine volume, we'll assess here urine volume 150 divided by this urine osmolality, 50, will equal 3 liter. This means your patient will retain 2 liter of fluid. Hypotonic is retained to produce. This will lead to hyponatremia. This poor salt intake and beer bottomania. Okay, this I hope this is clear now. You can read and it's easy to read again. Beer bottomania syndrome. This is a syndrome already characterized by history. Your patient is alcoholic abuse with hyponatremia and sign symptom of water intoxication, protein malnutrition, cachexia, not taken well, with poor oral intake, low solute intake, and no diuretic or steroid use. Urine osmolality less than 100, and ADH level may be suppressed on this patient because the patient already drinking more. Alcoholic with malnutrition and the cirrhosis, because this patient alcoholic now and malnutrition, and maybe with alcoholic liver cirrhosis. Even with hypokalemia, are at high risk for ODS with rapid correction of hyponatremia. Treatment of poor salt intake, beer bottomania, T-toast syndrome. What is your treatment? As we agreed before from a previous or last presentation, the first step, free water restriction, not free fluid, not soap, not juice, just a free water restriction. Concentrate on the first line of management for any patient with hyponatremia, free water restriction. Increase solid intake. Increase solute intake in your diet. If not enough or patient not taking one, just add sodium chloride tab 1 to 2 gram BO/TID or urea tab 10 to 30 gram BO/TID. All this sodium chloride and urea tab, just don't forget gram. Sodium chloride and urea is just to do more osmotic concentration inside our renal tubules and will drag more water to go out through your urine, and you will be polyuria. And you will lose water, and this will help to increase your body's sodium, serum sodium. High protein diet, same scenario. Protein will end by urea, and this also will be osmotic gradient inside. Increases osmolarity inside your renal tubules, will drag water and will lead to polyuria, and at the end will end by improving of your hyponatremia. Please, DCL alcohol intake, yes, this is the main treatment. Stop the cause. Why? This other trick I forgot to mention before, why normal saline not working with this silage? If we have 1 liter normal saline, 0.9%, contains 308 millismol. From where? We have normal saline. This includes sodium and chloride, 154. Each liter normal saline contains 154 millimole of sodium. This all diluted in 1 liter of water for each 1 liter normal saline. If you just calculate this 154 plus 154 will give you 308 in assumption of your urine osmolarity 400. You will excrete 0.7 liter. 1 liter input, you excrete 0.7 liter, I think will retain 230 ml in your body. Free water will worse your hyponatremia. So SIADH contraindicated to treat by normal saline. From where? From this. You can read later too. What will happen if you will give 3%? 3% normal saline is the same patient with SIADA and urine osmolarity 400. 1 liter normal saline contain 514 by 514, around 900 millismol sodium and chloride. And urine output will be 900 over divided by urine osmolarity, around 2.2 liter. 1 liter and urine output 2.5, 2.2 liter, you already negative minus 1.2 liter. So hypertonic work with Sayada, not normal saline. Okay, I hope that slide clear. You can read later too. Okay. Oh, hypokalemia. What is the role of potassium or hypokalemia and hyponatremia? I need you to concentrate at that point. If you have a patient with hyponatremia and hypokalemia, how you can manage your patient? Just what is the pathogenesis? What will be happening? Hypokalemia is the contributing factor for hyponatremia. How? We have here an extracellular fluid compartment, intracellular fluid compartment. We have here potassium around, just to give empirical number, around 4 or 5 milli equivalent or millimole, and sodium 140 millimole. And intracellular against 140 or 150 potassium and sodium around 4 or 5. Just to easy equation, when we have patient with hypokalemia, is extracellular, where intravascular. Hypokalemia here, what will be happen if I have hypokalemia here? This will drag sodium from intracellular to extracellular. I will take this potassium from inside the cell to blood, extracellular, intravascular compartment. From intracellular to extracellular. Extracellular means, as I discussed in the first slide, this intravascular or interstitial. Just the potassium will drag here because we have intravascular hypokalemia. We'll take potassium from the cell. And this winning potassium drawn from the cell will take water with him. And already positive charge will increase here. And next step, water after will take water and take potassium out here. The sodium will return back because we have already here positive charge and negative charge increase here to do electroneutral, to be electroneutral. Just the sodium will go inside the cell and will worse your hyponatremia. Easy mechanism. We have intracellular compartment and extracellular compartment. Extracellular include intravascular. And when I have hypokalemia, potassium will, by osmotic gradient from high concentration to low concentration, will come here and will take water with him outside and lead here more positive charge and more negative charge here. Sodium will drag to intracellular to do electroneutrality and will end by hyponatremia. Hypotonic hyponatremia. This clear now? I hope that picture is clear. Hypokalemia is a contributing factor for hyponatremia. The reason movement of sodium from extracellular to intracellular compartment. At the same time, potassium moves out intracellular to extracellular fluid compartment to maintain electroneutrality. Treatment potassium chloride alone will correct both. Why? When severe hypokalemia less than 2.5 milliequivalent per liter is present with hyponatremia, only KCl needed to correct the serum sodium to desired level. If your plan to give, if you like this patient, I need to give him normal saline, whatever, but pressure is low, like just give half normal saline with KCl, whatever, you will give 1 liter normal saline plus 80 or 60 KCl, at least to equal normal saline. Don't exceed, just give 1 liter half normal saline with around 40 KCl is okay. Don't exceed the total requirement. Don't give hypertonics. To be not hypertonic saline given to the patient and will lead to overcorrection and other complications. Okay, we agree now in the patient with hypokalemia and hyponatremia, just proceed only with potassium chloride, whatever tablet or IV. What is pathogenesis of this potassium chloride? Management only to correct both. When the KCl used as a treatment, potassium and chloride will move to intracellular. Hyperosmolarity, and it make hyperosmolarity to intracellular fluid. This will draw water from to the intracellular fluid, and this will raise your serum sodium. Please, again, when I am giving KCl. The KCl, potassium hydrochloride, will go direct because it already increased on extracellular, intravascular, and we have good amount, will move to intracellular. And this lead to increased osmolarity inside your intracellular fluid compartment. This osmolarity will draw water into intracellular, and this will raise your serum or extracellular serum sodium in the intravascular compartment. Also, when potassium moves to intracellular fluid compartment, the hydrogen will move out. Just to do electroneutrality. Hydrogen will move to extracellular fluid compartment. This hydrogen will be buffered by protein, by carb in extracellular fluid compartment. Then it will be converted to CO2 and water. This leads to decrease the plasma osmolarity, and the water moves into cells. And this will lead to increase your serum sodium. Is the second mechanism. All by dragging water to intracellular, whatever the mechanism, all both mechanism will lead to increase your serum sodium. I hope the slide also clear. Oh, when I have one patient came after marathon running, and this patient came to emerge by confusion, seizure, delirium, whatever the symptoms, and we'll discuss, we'll classify the symptoms in the next slide. Just marathon running associated hyponatremia, exercise-induced hyponatremia. You know, this girl already just drinking water, a lot of water during running, and this started to be drowsy here. And this what means exercise-induced hyponatremia. This is an emergency topic also to our emerge doc. Exercise-induced hyponatremia is a serious condition in marathon runner. ADH level will increase despite hyponatremia. Water consumption, this marathon running already drinking more water. Around 3 liters. Body mass index for most of them, you will find this body mass index around 20. Most of them not more than this, 20 to 25 kg per meter square. Excess loss of sweating. We saw here sweating all. And some of them maybe will take non-steroidal after that of feeling bare or cramp like that. And if running more than 4 hours, post marathon weight gain, if your weight start to increase after marathon running, if you are taking body weight after, this all will precipitate exercise-induced hyponatremia for our patient. If exercise-induced is a serious condition in marathon running, ADH will be high despite hyponatremia from pain, from the stress, water consumption more than 3 liters, body mass index, most of them low, and this amount of water, excess loss of sweet lead to loss more sodium. Patient, most of them taking maybe non-steroidal, salt and water retention more, and running more than 4 hours, post-marathon weight gain. Treatment, rapid correction indicated. Rapid correction. If the patient symptomatic, should be give him hypertonic saline, as we classified in the previous slide, previous presentation. And I will give you a nice classification now to guide you how to manage this exercise-induced hyponatremia. Approach for assessment and management of exercise-associated hyponatremia and heat exhaustion or heat stroke in our Hajj patient. Journal Wilderness and Environmental Medicine give us this nice approach. We have, when we receive post-marathon running patient with altered mental status. If this is okay, if my patient exhibiting new symptoms or collapsing during or after physical activity, if with altered mental status, yes. If a patient with confusion, altered sensorium, vomiting, seizure, coma, dyspnea, ataxia, collapse. If yes, always exclude other diagnosis. This severe exercise-associated hyponatremia, or heat stroke. If this severe exercise-associated hyponatremia, large fluid intake from patient may be drinking 3 or more free water, and you will find your patient obtundation and coma, seizure, dyspnea. What's your treatment for this patient? This emergency should give IV bolus 100 ml hypertonic saline and or whatever you like the approach. I give you 3 approaches before in the first presentation, and I will give you my summary today also to remind you what approach you like, and you can repeat every 10 minutes. But after you measuring your sodium or symptoms stop, our target to increase to 5 millimole in first hour. But here, this in other patient, chronic patient, but this patient, our target to reach normal because this acute hyponatremia now. It's safe to return to normal because the brain still no adaptation. The brain need 2 days, 48 hours to adapt to the acute hyponatremia. Okay, otherwise, transport to medical care. Other diagnosis includes hypoglycemia, hyperglycemia, and altitude illness, infection, myocardial infarction, endocrine cause, toxin ingestion, or drugs. Okay, but don't forget this to exclude. Maybe your patient taking any medication, you don't know. Maybe it is toxin related or drug related. Maybe you keep by chest pain or dyspnea. Maybe you should do ECG and to rule out hypoglycemia. You should check everything. Do routine investigation and treat with hypertonic saline. Other differential diagnosis: heat stroke, small fluid intake, confirmed or suspected temperature more than 40. This will be confirmed by these symptoms plus this altered mental status, plus any symptoms of seizure, coma, delirium, collapse, dyspnea, like that, and with temperature more than 40, temperature, aggressive immersion, conductive cooling, IV 1 to 2 liter normal saline, I think normal saline is the best option. Consider IV hypertonic saline if your case progressed to severe exercise-associated hyponatremia. You should use hypertonic saline. If your patient deteriorates from you, this heat stroke, okay? If your patient came by altered mental status, no, just weakness, dizziness, headache, nausea, vomiting, muscle cramp, weakness, dizziness, headache, nausea, vomiting, muscle cramp. If my patient like that, always exclude other diagnosis. Mild exercise-associated hyponatremia or heat exhaustion or dehydration. Heat exhaustion or dehydration. Mild exercise-associated hyponatremia, variable fluid intake, bloated feeling, and or weight gain, normal vital sign, no or cystitis. Treatment, what is your treatment? Fluid restriction, especially free water. Free water restriction, no emergency now, don't be hurry. Yeah, I will use hypertonic saline if my patient deteriorate. Otherwise, just observe until he will excrete all this free water he is drinking during the marathon run. You will fluid-free water restrict until diuresis. Okay, and you can do salty snakes in normal saline, normal sodium chloride tab or salty foods. Oral hypertonic solution, monitor for progression to severe exercise-associated hyponatremia. This patient with mild exercise-associated hyponatremia. If my patient heat exhaustion, dehydration, small fluid intake, serious orthostatic hypotension, dry mucous membrane, what will do this patient? Drink to convert, avoid forced fluid, and reset in the shed, cold water, dousing for cooling to comfort. Monitor for progression to heat stroke. This patient, just let him to drink cold water and to be immersed in cold water, and you can give also normal saline for him. If unable to tolerate by mouse due to nausea, vomiting, just use IV hypertonic saline. If unable to tolerate by mouse due to nausea and vomiting and concerning For heat illness, use IV. This is our patient here. Just use IV 1 to 2 liter normal saline. If IV isotonic saline administered, consider IV hypertonic saline standby if your patient progress to mild or severe exercise-associated hyponatremia. I hope this algorithm is clear and helpful, and I think this is a good algorithm to manage exercise-associated hyponatremia and the heat stroke and heat exhaustion and hydration. I think this is clear. Next, SGL2 inhibitor. Impact. Levlozin, this medication already, we think this medication is thinking, especially in diabetic patient, to control hyponatremia just by osmotic gradient, osmotic diuresis. Impact levlozin, this patient is a sodium glucose cotransporter 2 inhibitor, which is used as an anti-diabetic drug due to its induction of pronounced glucosiuria. Okay, glucosiuria lead to osmotic diuresis. Glucosiuria, because he will block this channel, SGL2 inhibitors will inhibit this channel responsible for glucose reabsorption via proximal convoluted tubule, lead to glucosiuria, and this will lead to osmotic diuresis with consequent increased excretion of free water, and this will lead to improvement our hyponatremia from free water loss with glucose. This is the mechanism of action. This is SGL2 inhibitor receptors here in proximal convoluted tubule will be blocked here. This is responsible for reabsorption, sodium glucose. All this will be blocked, and the glucosiuria doing osmotic gradient and will take water, and this water will go to more osmotic diuresis and more correction of our sodium. Oh, next question for us: who's the most important here? This Lasix or thiazide? Who is the most stronger as a cause of hyponatremia? Whose natriuresis, by other way, whose natriuresis and whose diuresis? Thiazide is natriuresis, more hyponatremia. This furosemide diuresis, more diuretic, not natriuretic, more water loss than sodium loss. And this natriuresis more sodium loss than water loss. And how? Why hyponatremia is rare with loop diuretics, furosemide or Lasix, compared to thiazide, metolazone, or chlorothiazide, or hydrochlorothiazide diuretic. Again, chlorosalidone is more stronger in as a hyponatremia cause more than hydrochlorothiazide, more than thiazide in the dopamine. Thiazide-induced hyponatremia, in observational study already, thiazide-induced hyponatremia around 13% of treated patients, around 13 to 14% of treated patients. Thiazide implicated in 26 patients of hyponatremia patients. Thiazide used in 75% hospitalized hypertension patients in retrospective analysis. What is the risk factor for thiazide-induced hyponatremia? If I have patient old age, women, low body weight, and increased incidence in summer and hot weather. Okay, thiazide-induced hyponatremia may lead to also hypovolemia from water loss too. What is the mechanism? Why loop diuretic here? And this normal person, all the problem here for medullary interstitial osmotic gradient, osmolarity here. This is the main player for this mechanism. What happened in our normal person concentration, osmotic gradient increase from 300 to 1,200 here. Difference here around 900. With loop diuretic, from 300 will go to 800, difference around 500. What is happening here? This is a normal person, this patient with loop diuretic furosemide will come here. What is the action of furosemide? Furosemide, where is his play? Where is his channel? This is the most common question you will ask. What is where Lasix work in our kidney tubules? The channel for Lasix or furosemide present on thick ascending limb of lobe of Henle. What is the name of the channel? Sodium, potassium, 2-chloride co-transporter. Sodium, potassium, 2-chloride co-transporter. If this working, this will lead to reabsorption of sodium here and will maintain this osmotic gradient within the medulla, and this will lead to reabsorption of water from this in normal person. Okay, and this will keep this osmotic gradient like that. The osmotic gradient will be high here because the water, all water absorbed, because we have high osmotic gradient from sodium reabsorbed from sodium potassium 2-chloride channel. If I block all this channel by Lasix, how Lasix is work? We just replace one chloride, an ion, and this will disturb or impair our channel. No sodium chloride reabsorption here. Osmotic gradient will drop here, will be hypotonic, hypoosmolality or osmolarity. And this lead to water will pass here because no osmotic gradient, you will lose your osmotic gradient here will drop here like this, and more water will be lost, more diuresis. I hope that's clear now. Second one, what is the mechanism of thiazide? We have a normal person, osmotic gradient from tubules up to distal of collecting duct. Normally, osmotic gradient will increase from 300 to 1,200. This is the normal because our channel here working and the osmotic gradient here is okay and taking water because the osmotic gradient is working well. In thiazide, same osmotic gradient here, our distal, proximal distal to distal collecting duct, same normal person. Oh, what happened? We are here, sodium, this thick ascending limb of lobe of Henle, site of working of Lasix or furosemide. This is still working. I am not touching this channel now. Sodium reabsorb it here and will keep your osmotic gradient. This will draw the water by osmotic gradient and will keep your osmotic gradient same normal person. What is the mechanism of action of thiazide here? Thiazide working on a distal convoluted tubule via sodium chloride co-transport. Sodium chloride to co-transporter, this channel will be paralyzed or blocked by thiazide. This leads to loss of sodium here and loss of water, and the sodium will go with some water, and this will lead to more natriuresis and more hyponatremia than Lasix or furosemide in thick ascending limb. From blocking the sodium chloride reabsorption, sodium will be lost and more natriuresis will be happening. Okay, I hope that's clear. My final home message for this topic of hyponatremia. I hope I cover the most important and the critical cases. My hope to send my message to all my colleagues to be comfortable when facing any acute hyponatremia, any chronic hyponatremia, and how can I deal. And I need you to be stable when you see any patient with hyponatremia. Just listen for all this, and I will give you a summary now for most of the most important point, just to put in your mind, your notes, and I hope to be beneficial for all. My home message: what is the definition of hyponatremia? Any hyponatremia less than 135, whatever is mild, from 130 to 135 is mild hyponatremia. 130 to 125 moderate hyponatremia, less than 125, whatever the number, we'll consider that maybe severe hyponatremia. Just to remind you, normal saline is the most common question. Normal saline bore 9% contain, each liter contain 154 millimole per liter. Ringer lactate, each liter contain 131 millimole per liter, and 4 millimole potassium. Half normal saline contains 77 millimole per liter. We have 2/3 and 1/3. This name of the solution, his name here is 2/3, 1/3. This already contains 1/3 normal saline and 2/3 T5 water. 3% saline, each liter contains 514 millimole per liter. Isotonic bicarb. When I have one patient CKD, whatever stage, and this patient not volume overload, I think is volume depleted with severe metabolic acidosis and the AKI into CKD or even AKI, and his sodium a little bit low and a little bit volume depleted, best solution to use isotonic bicarb if no sign of volume overload. How we can do this? Around 850 ml, 850 ml D5 water, and I will put this 150 here sodium bicarb. And you can start whatever your rate according to your patient and cardiac status and ejection fraction. If your patient tolerate, you can start by rate 75, you can increase 80, 100, 120 according to your patient. Okay, I hope this slide beneficial for all too. Just to remind you, by symptoms of hyponatremia, some patient may become asymptomatic, some patient came by nausea, vomiting, some patient came confused. Just to ask your patient, when you saw any patient with hyponatremia, you have nausea, vomiting, and when you discuss with him, you will know your patient confused or no, to assess GCS score for your patient. And sometimes you will find your patient fatigue, he unable to move like that, and his mood not in the mood. And sometimes patient complain headaches, lethargy, and weakness same. Your patient delirium, restlessness, and your patient agitated. Some critical came to emerge by seizure and coma and respiratory arrest. These other issues, emergency should be as emergency. Emergency is emergency. Just to remind my colleague, for management of hyponatremia, severe hyponatremia, as I mentioned, patient came by seizure, coma, or ERDS. If yes, I will go to emergency, IV 3% saline. I need to raise my sodium 5 millimole now, first hour. If symptoms still, you can increase another 5. You allow it to 10 millimole per hour. If you don't know this patient is chronic or no, you can use either 100 ml, multiply by 3 times, 150, as we discussed in the first presentation. And we can use this, just you can multiply what is the desired sodium by your body weight, as we discussed before, and give this amount 2/3 in the first hour and the remaining 30 minutes. If symptoms improved, yes, therapy for now we'll search for the cause of this hyponatremia. If not improved, I will continue. Hypertonic saline, 1 cc per kg per hour. Some doctors giving 10 to 15 to 20 to 50 ml per hour according to your monitoring. If your patient is safe in ICU, you can continue maybe 15 to 20 ml per hour, and you will check your sodium, serum sodium, and urine lysosomolarity and urine output every 2 to 4 hours. If I have moderate symptoms, just headache, nausea, vomiting, confusion, yes. With acute hyponatremia and the brain pathology, yes, you will go to emergency management protocol with hypertonic saline. If with acute hyponatremia and the brain pathology, no. And this patient came by these symptoms, just you can start, give 1 bolus of hypertonic saline, 3%, around 100%, and continue infusion and frequent follow-up of your sodium every 4 to 6 hours, okay? Or 1 cc per kg. But you need to careful monitoring. And our target, as I mentioned before, and I will mention next slide, in a high-risk patient, just 6 millimole per 24 hours. In low-risk patient, just maximum 8 to 10 millimole per day. Otherwise, if your patient has moderate symptoms, not acute, definitely acute hyponatremia, if yes, I will treat with hypertonic. If no, just treat as chronic hyponatremia and take your time to investigate for the cause. I hope this management protocol I discussed already in first presentation is clear, and I hope to keep in your pocket, on your notes, on your mind, your mobile, and don't forget this protocol to be easy for you. Just to avoid overcorrection of hyponatremia, especially patient less than 120, whatever is the number. The risk factor for all this, just to put in your mind, what is the risk factor? Severe hyponatremia, sodium less than 110, patient cachexia, patient liver cirrhosis, malnutrition, Other patient, alcoholic, severe hypokalemia. This is the risk factor for ODS. Take care. Either two. Good monitoring urine output, as I mentioned before, urine output, if increase more than 200 ml per hour for 2 hours, please, your patient will go to overcorrection. Keep the DVB standby. I don't have the DVB. What I will do? D5 water. You can give D5 water, 500 1 liter, and frequent monitoring your serum sodium, urine lights, urine osmolarity, and urine output. Okay. If your patient already high risk for free water excretion, especially patient with hypovolemia, and you correct him by normal saline. I have patient hypovolemic, hyponatremia, and they give normal saline. And this patient, when he rehydrated or repleted from this dehydration, he will do shut off to ADH will be stopped. ADH, antidiuretic hormone. If he stopped, the patient will start to be polyuria and overcorrection will be happening. If you have patient high risk, please give proactive prophylactic DVB or D5 water standby. If you will think your patient will go to overcorrection. If overcorrection already happened, you should give DVB or D5 water. Okay? And we discuss all this in the first presentation in details. Don't forget, if your patient with no symptoms and the patient is stable and clinically, vitally, everything is okay, and the patient with chronic hyponatremia, just to remind you, please check his volume status. This patient volume depleted, volume overload. This effective arterial blood volume. If low, if no, we'll go to the second algorithm. If your patient actually volume depleted, yes, we'll check this patient as volume extracellular fluid volume expanded or no. If expanded, if yes, we'll go to the algorithm for heart failure and liver cirrhosis. If my patient not edematous and his volume depleted, we'll go to this primary adrenal insufficiency and diuretic, salt intake, low salt intake, diarrhea, especially patient with gastroenteritis, cerebral salt hosting, already discussed in details in the previous presentation. If my patient who is not volume depleted, not dehydrated, and not on thiazide, we'll ask the patient, you are on thiazide, you will check if GFR is low. If no, for this pause, you will check urine osmolarity. If less than urine plasma osmolarity. If is no, I will check urine sodium, urine chloride. If less than 30, if it's no, I will check serum cortisol and the TSH. If it's yes, maybe my diagnosis either adrenal or severe hypothyroidism. Otherwise, if this negative for both, we'll go to side H. And this all discussed before in previous presentation. Chronic hyponatremia, my message clear for all my colleagues. Any chronic hyponatremia, please go slow. Don't be hurry. Don't be correct. If a patient high risk, just enough 60 millimole per day is perfect. If your patient low risk, 8 millimole, maximum 10 millimole per day is perfect. Go very slow, take care. Any patient with severe hyponatremia will go to high risk for osmotic demyelination syndrome. If I have patient hyponatremia and hypokalemia, will go to high risk for osmotic demyelination syndrome. If patient with malnourished, poor oral intake, cachexia, elderly patient is high risk. Alcoholic, same. Liver cirrhosis, same. High catabolic patient, already same. What is our guidelines to treatment? For my last message to all hyponatremia, please, any patient with hyponatremia, free water, not soap, not juice, not other, just a free water restriction around 800. This we can decide. Sometimes patient came to emerge at night, midnight, and the patient hyponatremia, and I think this patient polyuria, polydipsia, drinking more 2 to 3 liters per day. Is from where I know, from history, from vital signs, from the assessment. My patient not volume depleted. Just keep him in NPO all night and repeat the lab after 4 or 6 hours. And check urine output like that, urine lysis, urine osmolarity, as we mentioned before. After 4 hours, you will find rising in your sodium. This you are in correct track. Don't forget, careful monitoring your urine output. This is the first sign of overcorrection. If the urine output increase 200 ml per hour for 2 hours, this first alarm sign for overcorrection of hyponatremia. Rate of correction, as I mentioned before, 60 millimole per liter per 24 hours if patient high risk for ODS, osmotic demyelination syndrome. If low risk, 8 to 10 millimole per liter per 24 hours. this accepted for this patient. If I have patient hypovolemia and I receiving normal saline and the patient rehydrated and now will be ADH will be suppressed, keep the DVB standby beside your patient. To avoid overcorrection, monitor plasma sodium, urine lysis, osmolarity, and urine output frequently. Okay, to avoid overcorrection, at least urine output hourly, and urine plasma sodium and urine lysis, osmolarity maybe every 4 hours good. If you are in the ward, 4 to 6 hours okay. If you are in ICU, you can ask 2 to 4 hours to repeat the lab. DDVB, don't forget DDVB or D5 water. If you don't have DDVB, what you do? Just DDVB, what is the mechanism of DDVB? Just look the water output or urine output. You retain the water in your body and keep your sodium not exceed our limit of your aim of your management. And consider proactive if you have, just keep the DVB ready and consider proactive. Proactive means prophylaxis before overcorrection will be happening, especially at high risk patient for ODS, as we mentioned, malnutrition, cirrhosis, hypokalemia, alcoholism, severe hyponatremia. And almost avoid correction hyponatremia faster than 10 millimole to 8 millimole per day in low risk patient. If high risk patient, 6 millimole is enough. Continue slow rate of correction until plasma sodium reach 130. This is my target to be keeping my patient to safe target if any plan for this shot. In acute hyponatremia, you can raise to normal, even normal. If you clear, have this patient sodium 135 and after surgery or after any operation or any intervention, sodium drop to 120, I can raise this to 130, no problem. But better to increase 10 millimole per day to be safe side too. The last message for you, don't forget this message, 8 millimole, 10 millimole in normal person with no risk factor for osmotic demyelination syndrome is accepted. High risk patient, please don't exceed more than 6 millimole per liter per day to avoid risk of osmotic demyelination syndrome. And if you didn't hear the presentation for osmotic demyelination syndrome, please, I advise you to hear at least to prevent any complication from your management to any patient. What is sodium target or numbers? We just alarm you, you are overcorrect your patient. If you increase more than 10 millimole in the first day, if more than 10 millimole before the first 24 hours, you are overcorrecting now. Take care. Check your urine, check your urine output, check everything, and try to look your patient, either B5 water, either DDVB, as according to the available with you. If more than 18 millimole per liter in the first 48 hours, take care. If it's running more than 18, within 2 days, just take care also. Patient will go to overcorrection, especially patient who is high risk. If you have more than 8 millimole per liter within 24 hours, maybe after 6 hours from start management by hypertonic, whatever, or salt tab or urea tab, whatever you start to manage your hyponatremia or free water restriction, please, just this alarming for you. If 8 millimole, I have my sodium now 120, and after 4 hours 128. Oh, just you should lock your patient. Don't allow him to go more than this. I hope this message clear. Okay. This is my reference for anyone need or like to read more details for hyponatremia. I let him to enjoy. And this also reference, and don't forget this Dr. Kamil box and this radiology fluid electrolyte acid based disorder is a very nice box also too. And any question you can write on my chats for any presentation, any clarification. I am ready for that. ونسألكم الدعاء من القلب وبالتوفيق والسداد وإن شاء الله. أنا حاولت أنهي موضوع الهايبوناتريميا، هو طول وأنا عارف إنه طول لأنه يستحق إنه هو يطول. الموضوع مستحيل حد يقدمه في برزنتيشن واحدة. أنا اتكلمت عن الموضوع على أساس الحالات اللي فعلا اتعاملت معاها والحياة المهمة وبدأت بالمهم فالمهم. وموضوع الهايبوناتريميا معروف دايما لكل دكاتره الكلى ودكاتره البطنه من ارزل الموضوعات اللي تتكلم فيها وتتكلم عنها. لكن بصراحه انا حاولت اقدم كل اللي اتعلمته فيها بصراحه، ونسالكم الدعاء والتوفيق. وان شاء الله موعدنا في المحاضره القادمه ان شاء الله نتكلم عن الهايبوكاليميا، وهنحاول نقدم الهايبوكاليميا في 1 برزنتيشن وهنحاول نقدمها بطريقه سهله جدا، وان شاء الله تكون ميسره وبطريقه مختلفه تماما عن اللي احنا اتعلمناه. ان شاء الله تكون مفيده للجميع ولجميع مرضانا، ونسالكم الدعاء بالتوفيق، واهم حاجه الصحه والعافيه والستر، الصحه والعافيه والستر والبركه. ولا تنسوا دائما الصلاه والسلام على حبيبنا محمد صلى الله عليه وسلم. ونسالكم الدعاء من القلب، ونلقاكم ان شاء الله في فيديو قادم باذن الله. والسلام عليكم ورحمه الله وبركاته.